Right. Well, good afternoon. I would like to welcome you all to today's webinar. I'm Rebecca Stokel. I'm the Senior Vice President at Education Development Center. And today's webinar is a collaboration of two ongoing convening activities at the National Academies. I'm the co-chair of the Forum on Aging, Disability, and Independence. And that's a role that I share with my colleague Steve Ewell from the Consumer Technology Association Foundation. I'm joined today by Peggy McGuire, who is co-chair of the Roundtable on High Quality Care for People with Serious Illness. We're grateful to the sponsors of the Roundtable and the sponsors of the Forum for supporting the work of our two activities. Even before the COVID-19 pandemic, the significance of social isolation and loneliness was becoming increasingly evident. And in February 2020, the National Academies released the report, Social Isolation and Loneliness in Older Adults, which documented the substantial impacts of social isolation and loneliness on the health and well-being of older adults. Now, little did we know then that the impending global pandemic would exacerbate these issues and amplify the severity of the negative impact of social isolation and loneliness on people's health, particularly those nearing the end of life. A study released earlier this year explored the epidemiology of social isolation and loneliness among individuals during the last years of life and will serve as a foundation to today's discussions. This webinar is being recorded and the archived video will be available at the link provided. Due to time and capacity constraints, we will not be using the chat function on Zoom. I would now like to turn things over to my co-host for the day, Peggy McGuire.
Thank you very much, and hello everyone. I am Peggy McGuire. I'm the president of the Cambia Health Foundation, which is the corporate foundation of Cambia Health Solutions, headquartered in Portland, Oregon. Since 2007, the Cambia Health Foundation has invested over $80 million to advance person-focused and economically sustainable healthcare. Our signature program is called Sojourns, through which we advance palliative care access, awareness, and quality to improve the care of people with serious illness and their loved ones. And through our Sojourn Scholar Program, we invest in emerging palliative care leaders across disciplines, geographies, and practice settings. Each scholar receives a 2-year, $180,000 grant to work on an innovative project that will advance the field of palliative care while also working on their own development as a leader. Today, we have invested in 84 truly remarkable emerging leaders through this program. I also have the great pleasure of serving as co-chair of the Roundtable on Quality Care for People with Serious Illness, along with Dr. James Tulsky of Dana-Farber and Harvard Medical School. I would like to join Rebecca in thanking the sponsors of the Roundtable, without whose support webinars such as this one would not be possible. And now it's my great pleasure to introduce you to Dr. Carla Parasunotto, Professor of Medicine at the University of California, San Francisco, who will be moderating today's webinar. Take it away.
Thanks so much, Peggy. And thank you all of you for being here. It is such a joy to be here and really to talk about a topic that's near and dear to my heart, and I think a topic that many of us have become familiar with during the pandemic. I will be introducing each of the webinar's participants after the initial presentation, but you will be able to read more in depth about the speakers and bio sketches online. So to start, I am welcoming Dr. Ashwin Kotwal, who is an assistant professor of medicine at the University of California, San Francisco. He will give an overview of a recent paper published on the epidemiology of social isolation and loneliness. And after his presentation, I will welcome him and the rest of our participants for a moderated discussion. So Ashwin, so great to have you here as my friend and colleague and expert. So thank you so much.
Thank you so much. Thank you so much, Carla, for the really nice introduction. And I'm so thrilled to be here to discuss this work with you today. I'm just going to share my screen. Okay. So today, as just mentioned, we'll be discussing the epidemiology of social isolation and loneliness among older adults during the last years of life. We'll be discussing three primary topics. The first is I'll briefly touch on definitions of loneliness and social isolation, and I'll provide background on the epidemiology of these two factors in the general population of older adults. The second is we'll examine experiences of loneliness and isolation, drawing on nationally representative data from the Health and Retirement Study. And third, we'll apply some of the lessons of our study to clinical practice and think about implications during the COVID-19 pandemic. So first, definitions. We generally think of loneliness and social isolation as related but distinct social risk factors, as shown in the Venn diagram. Loneliness is a subjective feeling that your social relationships are lacking, or a discrepancy between one's actual and desired level of social connection. A popular phrase is, you can feel lonely in a crowd. So people may have many relationships or even be married and still feel lonely. A growing body of literature has shown strong associations between loneliness and poor health outcomes. These include depression, functional disability, physical symptoms like pain, and even death. In contrast, social isolation is a more objective deficit in the number and frequency of interaction with family, friends, or the community. So how often are people actually seeing their children or going to religious groups? Social isolation may not be distressing for all, but it's associated with medical risks, which is related to isolated individuals not having limited access to key caregiver, financial, or medical support. So the key point here is that loneliness and social isolation are conceptually distinct with different potential mechanisms of impact on health. So how do we measure loneliness? The most common tool in the US is the 3-item UCLA loneliness scale. This scale asks 3 questions about whether individuals feel left out, feel isolated, or feel they lack companionship, and ranges from 0 to 6 points. Prior research has used 1 point or higher to signify occasional loneliness, which is tied to a number of health outcomes. And for our study, which I'll discuss more in a bit, we used a cutoff of 4 points or higher, where individuals responded often to at least one question, and that might signify a higher level of emotional distress. For social isolation, there is more variability in scales that are used. Here is one well-known scale developed by Andrew Steptoe and Aparna Shankar, which examined 3 domains of social isolation, including marital status, contact with one's social network, and participation in community or religious groups. We anticipated that at the end of life, people may selectively prune their social lives to focus on their most important social relationships. This is based off of work developed by Laura Carstensen, known as the socio-emotional selectivity theory. Because we had detailed information on social relationships in our study, we were able to adapt a prior scale to have a higher threshold for determining social isolation. This included 3 domains, including household and court contacts, including 3 items: marital status, living alone, and the presence of nearby children; social network interaction with children, family, or friends using multiple modes of communication, and that communication occurring at least from one source, at least monthly, and any community engagement in the last year of life. So coming back to our Venn diagram, in the general population of older adults, prior literature indicated that loneliness and isolation were quite common. About 40% had occasional loneliness and 10% frequent loneliness. And for social isolation, about 20% were isolated based on prior scales, and about 10% met our stricter definition of isolation. And so why should we care specifically about the last years of life? Prior work by Dr. Karen Steinhauser showed that people really care about their social well-being at the end of life. In a national survey of seriously ill patients and bereaved caregivers, for example, nearly everyone wanted someone who will listen. 85 to 91% wanted to share time with close friends. 81 to 95% wanted the presence of family, and the vast majority wanted to be able to help others. For loneliness, our clinical experiences suggest that older adults may be less able to cope with loneliness compared to earlier in the lifespan, when loneliness might be a transient feeling, which actually motivates people to connect with others. And for isolation, older adults may become more isolated as they experience widowhood, disability, or cognitive impairment. And individuals who live in isolation at the end of life may struggle with unanticipated needs related to emotional, financial, or caregiver support. As mentioned before, a report by the National Academy of Sciences published in February of 2020 really highlighted the need for clinicians to be aware of and address these social needs. So let's turn to then experiences of loneliness and social isolation at the end of life. We use data from the Health and Retirement Study, which is a nationally representative sample of adults over age 50. Since 2006, the HRS has included detailed questions on loneliness and isolation. And to examine the last years of life, we selected individuals who died while enrolled in HRS who were interviewed within the last 4 years of life. That was about 3,600 adults. We further classified individuals based on the number of months between the interview and death. We use scales consistent with prior literature that I just presented. As a reminder, loneliness was measured using the 3-item loneliness scale. We classified individuals as occasionally lonely or frequently lonely based off of the 4-point threshold. Social isolation was measured using a 15-item scale indicating minimal contacts in the household, minimal social interaction, and minimal community engagement. For our analysis, we had 2 primary components. The first was we determined the prevalence overall and by time prior to death. And the second is we used multivariate logistic regression to determine risk factors within the last 4 years of life of loneliness and isolation. So first, I'll discuss the prevalence. Here are our results for loneliness. On the left-hand side is the overall prevalence in the last 4 years of life. 2/3 of older adults occasionally felt lonely, and nearly 1 in 5 experienced frequent loneliness. This was about double the rate of the general population of older adults. We then examined whether the prevalence was different over time, as shown on the right-hand side. On the x-axis is time prior to death, broken into 3-month intervals, and the y-axis is the prevalence. The dots represent unadjusted prevalence estimates in each 3-month interval, and the line is the adjusted prevalence. The prevalence of loneliness increased slightly over the last years of life, but these changes were not significant. How about for social isolation? And again, these were individuals who had no household contacts, less than monthly interaction, and minimal community engagement. On the left, the overall prevalence was around 1 in 5 older adults. And when we examined the prevalence by time prior to death, we found that there was a significant increase from around 18% 4 years away from death, gradually increasing to around 27%. And you can see the raw prevalence was over 30% in the last 6 months of life. You may be wondering, how can we be sure that loneliness and isolation aren't just getting at the same issue? So we examined the correlation between each measure, and we found that only 5% experienced both in the last years of life. They were weakly correlated with a correlation coefficient of about 0.1, suggesting we should think about these as generally separate social experiences. Next, I'll discuss risk factors. Here are the risk factors for loneliness. And you can see that there are a large number of risk factors, which I've broken down into 3 categories based on color. First, there were sociodemographic risk factors, including female gender, being unmarried, and poverty. Poverty was actually the strongest risk factor in our model, ranging from 13% for those with a higher net worth to nearly 30% for people who are living in poverty. Medical conditions and symptoms that emerged were cognition, ranging from 16% for those with normal cognition to 26% for those with mild to moderate dementia, as well as pain. And lastly, there were a number of functional impairments that were important. These included difficulty with preparing meals, difficulty walking, vision impairment, hearing impairment, and incontinence. For social isolation, there were fewer risk factors, but I want to draw your attention to a few risk factors that were common to both loneliness and isolation. That included, again, net worth, which was the strongest risk factor in our model, and several functional impairments, including difficulty with meal preparation, walking, and hearing impairment. So next, let's think about our key findings and clinical implications, and this will really lead into our panel discussion. Our first finding was the prevalence in the last 4 years of life. 1 in 5 older adults were socially isolated, and this increased to 1 in 4 older adults prior to death. And 1 in 5 older adults reported feeling frequently lonely. So coming back to our Venn diagram, we can see those prevalence estimates. What is the implication here? Well, in the last years of life, when individuals may value social well-being and often need more support from others, substantial numbers feel frequently lonely, and many are cut off from emotional, financial, or caregiver support. The second is, while loneliness and isolation are often confused as being the same, our results provide more support that they should be viewed as related but distinct. Only about 5% of people had both, and more people had one or the other. The third is we identified risk factors which strongly predicted experiences of loneliness or isolation, which should be considered in screening strategies or can potentially inform intervention strategies. How can we apply these findings to clinical practice? Well, our prevalence estimates suggest that we should do a better job systematically identifying loneliness and social isolation, which are often poorly recognized. Loneliness is not universal, and we shouldn't assume who is or who is not lonely based off of their number of social connections or prior diagnoses. There are screening tools that are available, although there is limited research on their use in clinical settings. The UCLA loneliness scale is a reasonable option to use for now. In addition, there are short measures of social isolation that can be integrated into the electronic health record system. Simply identifying and providing space for a patient to discuss these topics can often be therapeutic. The second is if people screen positive for loneliness or isolation, we should think about why they are lonely and focus on those mechanisms. I think about interventions in 3 ways. The first is direct interventions, which try to improve people's social connections or perceptions of loneliness. Examples might include hospice volunteer programs, telephone friendship lines, or meaning making or mindfulness therapy conducted by chaplaincy. Indirect interventions might target modifiable risk factors That could be as simple as providing hearing aids or providing mobility devices for functional needs. And third, we should be aware of and actively address downstream consequences at the end of life. Socially isolated older adults may have trouble qualifying for hospice because they lack caregiver support. They may miss appointments or need help with transportation. They may lack a healthcare proxy and so need early engagement in advanced care planning. Individuals who are lonely may need more emotional support, and they may have more amplified experiences of pain, depression, or prior experiences of trauma. And lastly, we should consider policy implications. Social isolation and loneliness were highly prevalent many years prior to death. And so preventive strategies several years earlier in the life course that maintain or enhance existing relationships might have positive downstream consequences at the end of life. We should also think about how we can incentivize earlier interventions as well as interventions later in the lifespan. At the end of life, we should also think about how we might reprioritize some of what we spend on medical care towards social care, where we might more greatly impact quality of life. A number of countries have really helpful models. For example, the United Kingdom's National Campaign to End Loneliness is a really helpful model about how an integrated national effort can meet this complex challenge. So with that, I'd like to thank my mentors and collaborators who are listed here. We're also supported by funding from the National Institute on Aging, as well as the National Palliative Care Research Center. Thank you very much.
Fantastic. Ashwin, thank you so much. I feel very lucky to be your colleague and a collaborator on this work, and just seeing what you presented is just really amazing and helps set the stage for our discussion. I have the pleasure now to welcome my friend, colleague, and mentor, Dr. Christine Ritchie, who is the Director of Research in the Division of Palliative Care and Geriatric Medicine at Harvard Medical School, and the Director of the Mongan Institute for Aging and Serious Illness at Massachusetts General Hospital. Christine, so great to have you. And then we also have joining us Dr. Karen Steinhauser, Professor in Population Health Sciences and Professor of Medicine at Duke University School of Medicine. Welcome to you both. Thank you so much for being here. So with this information that Ashwin just presented to us, Ashwin is really leading a lot of the field in terms of how we think about loneliness and isolation in the context of serious illness and end-of-life care. But I think more broadly, the question that I have to start with, Karen and Ashwin actually, is how do we put this in the context of translating these research findings to real life work that we do in terms of quality of life for people as they approach the end of life? And I ask this in part because often, as we start thinking about individuals nearing the end of life or with serious illness, we think very medically, perhaps sometimes, and only think about pain, only think about nausea and shortness of breath. And the question is, clearly with what Ashwin is showing, we're missing something. So how do we translate this?
Well, Ashwin, thanks so much for your presentation, and happy, since you've had the floor, to, if you want to jump in for a moment, and then I'm happy we can begin the discussion.
That sounds wonderful. And it's a great question, Carla. And I've actually looked to Karen's work substantially in terms of trying to answer these questions. From a loneliness and isolation standpoint, I think one of the key things is there's a lot of amazing work that's being done in the field right now by community organizations, by many different clinicians from a variety of disciplines, including social work, chaplaincy, psychology, who are recognizing that loneliness and isolation cause a significant amount of distress at the end of life. And so I think there's a lot to be done in terms of learning from different disciplines about how people are capturing what's going on and connecting people to interventions that make sense. I mentioned a few interventions, things like volunteer programs, friendship lines, meaning-making therapy or mindfulness therapy. So I think part of this is there's a lot of great intervention work that's being done, and it's about developing some of the evidence base around those interventions. And the second part is, how do we actually capture these concepts at the end of life when people's priorities, social priorities might be changing, when the concepts of loneliness and isolation may be slightly different compared to earlier in the lifespan. So I think we need to be doing a little bit more work here on adapting some of our existing measures to these unique populations.
Sure, and just building on that, I really agree. I think that, and in part the way you framed the question, I think saying sometimes we come at this with a very medical lens, and Ashwin saying, there are other disciplines that have a rich tradition in exploring this in terms of the evidence base. Certainly in sociology and psychology, there's a long, deep, decades-long history looking at social support, social isolation, subjective versus objective sense of social support, which we now, in this language, call social isolation and loneliness. So I think we have that to draw upon, just even in our evidence base, and then with our colleagues around the bedside, as you said, from other disciplines. I also think the way you framed the question was so important because, we come from a medical lens often, that tends to be a problem-focused approach. And how do we order what the problems are? And we can think about this as, what are the needs of the people who are this ill? And I think, while that's important in terms of screening, there's also the opportunity to think about, what are the resources that this person brings to the experience? And so I love thinking about the construct of loneliness also in this multidimensional way. So a couple clinical implications, right? That one, we're sensitized even on the needs end, that there are aspects of the extent to which I feel connected to a confidant. How connected do I feel to close family and friends, and how connected do I feel to a community? And sometimes individuals and clinicians can think, someone has a real resource in that area, but there might be deficits in other parts, and that cause us to then experience loneliness. So really understanding that full picture, I think, is really important in terms of needs. And then in resources, what opportunities do we have to explore what this person has to bring from a lifetime that may have been tamped down because of a focus on really shifting into the patient role and all that comes with attending to medical needs? And how do we help them amplify some of those strengths that exist and connection? Can be the case, our findings from years ago that seem to keep holding true about how important it is for people to contribute to others. Gosh, that's such an important way that we move out of a sense of loneliness, not just by connection that's coming toward us, but that we have an opportunity to give. And then the last piece that I might offer is, again, in the evidence base, when we look at how some of these items move with other constructs, I think looking at the role of spirituality is deeply important as a resource, because we can think about relationships that people have to a sense of meaning and purpose being a resource, the relationships that people have with others that might be part of that meaning and resource, but also what are their relationships intrapersonally with themselves, their inner life. And for many of the patients and families we work with, what about a relationship to a transcendent? And that transcendent, I think, is an underexplored area of potential connection and resource that may have a powerful impact on sense of connection. So a few thoughts from
And with those thoughts, I feel like we need like 5 more hours of discussion, but unfortunately, that is not what we have today. But Karen and Ashwin, your thoughts are really helpful for me. And I think if I'm humble for a moment, I can think about how many times I've failed as a clinician because I go in and I think, okay, heart failure, I know what I have to do. These are the symptoms, and I'm not looking exactly at what is the person actually saying that they want, and what they may want may be very different from what I want. And so how can I expand my lens to be open and hear what really is that person's resources and the areas that where we can help. And I think with that, I'm so thrilled that we're starting to open up our discussions to not just be so medical and to think about other aspects. But I'm struggling a little bit also with, there's so much focus on quality metrics and measurement. And I think sometimes when I've led programs and I tell my clinicians, what are the quality metrics? They want to, they're so angry. They're like, oh God, one more thing you're measuring. But I think there's a point that there really is work we could do here in terms of, can we turn any of this into truly quality metrics and things that we value in the work that we do, whether it's in palliative medicine, in hospice, in general medicine. And Christine, I know you are quite the expert in this area and have done a lot of thinking and writing about quality. So can you think of, is this an opportunity for us in the field of palliative medicine to look at a topic like loneliness and isolation and turn it into a quality metric? Is that possible, or are we shooting ourselves in the foot?
What a great question. And thank you, Carla. I think before we even think about a quality measure or metric, we have to do what's happening today, which is to sort of shed light on this as part of our overall lived experience and something that creates important quality of life, meaning and purpose. And as we shed light on this work and we actually demonstrate its relevance to clinicians, then I think it will seem more natural to say, in addition to asking about somebody's pain, is it worth also opening the door to other experiences that are important to them? Things like, how are you feeling about the connections in your life? How are you feeling in terms of your sense of loneliness or lack of loneliness? What are those transcendent issues that are important to you? Opening that door and normalizing it and demonstrating its relevance, I think, is the first step. Once we have clarity and a sense of buy-in that is an important piece of what we should be doing to support people who have serious illness, then thinking about those quality measures and how we can, again, make them not checkbox measures, but really measures that influence our work in a positive way becomes a natural next step. And so this gets back to, well, then how would we think about doing that? And first, I would say is we need to have mechanisms, and Ashwin, you touched on this in your presentation, to start asking these questions, natural ways for people to open the conversation. Most clinicians feel uncomfortable asking questions they don't know what to do with. So in addition to asking questions, we also need to provide some way of giving that clinician the tools and the support to be able to then be in a place of understanding, to communicate a desire to understand and a desire to be curious. And in addition to that, the opportunities to guide if that's important or relevant to that person living with serious illness. All of those then can be used as a starting point for measures. And I would suggest or posit that the most powerful measure here is asking patients what their lived experience was with that interaction. Did they feel like they were being asked in a sensitive, thoughtful, and non-judgmental way about their experience around isolation or loneliness? Did they feel like their clinician really was trying to understand what was important to them? And were they feeling like they were getting the kind of guidance that they were ready for or seeking to receive? So this is where I think patient-reported outcomes or persons-reported outcomes become so important as a quality indicator.
And taking that, Christine, and this is really open to all of us, but often when I talk to people, both in medicine and outside of medicine, or community-based organizations, where we're trying to get a sense of, can we ask these questions in a clinical way, or rather that's relevant to the care of this person? get a lot of pushback and they're like, oh, I can't ask that, or that's just not the right question. And so I'm curious what all your experiences are, both from a research perspective, but again, into real life. There is an importance of two things. Is are we consistent in how we get this information so that when we ask someone about their lived experience, we understand, yes, we're talking about the same thing, loneliness versus isolation, for example. As Ashwin mentioned, the correlation is actually very small, yet they're often talked about as the same thing. And so there's this part that I struggle with as a researcher, because I'm like, no, we have to be very careful to be specific about what we're asking, but then you don't want it to be so formulated that it does feel like I'm just checking a box, right? There's also a lot of work being done in natural language processing. Is that what we should be doing instead? I was just at a conference at AMIA, informatics conference, and there's a wonderful poster that really showed that really, if you read the social worker notes, and if you did natural language processing there, it's probably like the most important information, yet we don't incorporate it into the rest of our assessments. So just want to throw those thoughts out there to see what you think about that.
Yeah, I'll jump in here. I think there's a lot to unpack there. So, in terms of talking about loneliness and isolation, you're right. You don't want to make this a checkbox experience, and Christine alluded to that as well with quality metrics. I think one of the things I've noticed clinically is that when you talk about this, part of it is about building rapport and building relationship with the person who's in front of you. People really care about their social lives, and they feel heard when clinicians ask about what's going on, ask about those really important aspects of their lives. When I talk about loneliness, I think a lot of prior literature has shown that this is a really sensitive topic, and there can be a lot of stigma attached to self-identifying as lonely. I think that's one of the reasons why so many scales in the past avoid mention of the term loneliness. We're asking about feeling isolated, feeling like you lack companionship, feeling left out. The pandemic, I think, has probably changed a lot of these experiences, though. It's normalized a lot of experiences of loneliness, the discussions around this topic, and the recognition that it's related to health, that people really are impacted when they feel loneliness, especially for a prolonged period of time. So I think there's a lot of opportunity here to continue to normalize these discussions around loneliness, to ask people, how often do you feel lonely? Or to use one of these scales and use that as a starting point to then have a larger discussion. Often when we start, just asking about this, it can frame or shift the priorities for the overall clinical discussion and kind of move towards, as Christine mentioned, the patient-related priorities. And we can start shifting from medical goals to social goals when those are the priority. How can we enhance your care so that you're able to spend more time with friends? Or as Karen mentioned, how can we, enhance your time so you can feel up to volunteering or giving back to others? So I think there's a lot of opportunity here, especially with the pandemic, normalizing these discussions.
And maybe just to add to that, Ashwin, I think also there's this opportunity to be present to someone in their place of difficulty or suffering. And in their place of feeling that deep sense of loneliness. Sometimes people want to be heard, and they may or may not want us to help them fix it, but to really to be heard and to listen. And I think that's the other thing that I would say that is true around these kind of questions that we're talking about, is that asking them offers us an opportunity to go deeper in a relationship and to listen and give someone else the opportunity to be heard and feel like someone is bearing witness to their suffering, to their difficulty.
And it's one of those times, building on that really the sort of screening for it becomes the intervention, in part because the how many times do people who are seeing a clinician so frequently during the course of an illness, if seen, if heard, that connection mitigates the feeling of loneliness while going through that illness. As Christine said, it's not that maybe the underlying cause of what is happening physiologically can be solved, but to not be abandoned in that, to feel human connection during that is an antidote.
I couldn't agree with you more. And I think that we don't give enough service often to, or credit to, the role of bearing witness and of being there and being present. And I think if we can communicate more of that it's not about fixing everything, which is such an egocentric way that I have to fix this, but rather let me listen. It's very humbling, I think, to get to that point. And I think, putting my geriatrician hat on, I think we would have much less polypharmacy and issues if we actually ask people, do you want me to do something about it? Because often, when I have stopped with some of my patients and said, okay, just give me a list of all these things. Do you want me to fix it? And often it's like, no, I just want you to know. And I'm like, whoa, thank you for that gift. Thank you for that gift. Someone mentioned the P word, the tiny P word called pandemic. And so I think I would be remiss if we didn't spend a little bit of time talking about the pandemic, in the sense that, there's a lot of generalizations made, and potentially because we are ageist, potentially because we don't want to hear about people's lived experiences. But there's this assumption that everyone just did poorly during the pandemic, and particularly older adults, and particularly those with serious illness. Now, my sense is that, the COVID pandemic has really allowed us to have these more open discussions because the word isolation feels more relevant to people, social distancing, loneliness for some. But I'm wondering, Ashwin, if you could share a little bit about the findings from our study here in San Francisco and the Bay Area, but also for all of us to really reflect on, is there something that we have learned from the pandemic about this topic in a positive way, both the positives and negatives, and how do we move forward and translate that to our current practice?
Yeah, it's a great question, and I think on everybody's mind. Loneliness and isolation, I think, unsurprisingly, they were amplified by the pandemic. Especially when restrictions were first put into place, it really disrupted people's social lives. Having said that, I think there have been some positives that have come out of the pandemic. You mentioned, normalizing discussions about loneliness. Many older adults have also shown remarkable resilience to social restrictions. I think our study in the San Francisco Bay Area captured stories of older adults who really drew on past life experiences, who are able to find ways to cope positively, to actually support other family members, and to also take on new technologies and these kind of new forms of interacting with others, and kind of just bring them into their daily routines. Having said that, I think there are people who have been left behind by many of these restrictions and are really suffering and continue to suffer. Individuals in nursing facilities who have been really isolated from family members and not able to support their family members who are outside of nursing facilities. Individuals who haven't been able to feel comfortable with technologies, including video interactions and others, or where technology and these virtual interactions are just not an adequate substitute for in-person human interaction, especially at this stage in the pandemic where we're more than a year and a half into it. And I think people who have had pre-existing psychological conditions or who have had challenges emotionally coping. So I think we need to, there's a lot of positives that have occurred during the pandemic, but we need to be aware of who has not been doing well, and how can we help meet their needs?
That leads me to Christine. I believe you did some work recently at looking at homebound populations and who's been left behind, and I'm wondering if you can share some light on that.
Yeah, thank you for asking that question, Carla. So we looked at people who are homebound, and we've been following this population for a number of years. And we saw, much to our surprise, essentially a doubling of people who became older adults who became homebound. That is, they rarely or almost never left their home over the previous month during 2020. And what was most striking to us was how Black older adults and Hispanic Latino older adults were more likely to be homebound than their white older adult counterparts. And the part that was perhaps the most disturbing to us was that in addition to that, many of those same homebound older adults were unlikely to have access to the internet, to be less likely to be using a computer or to have a regular web-based interaction. So what that meant is that both from a healthcare perspective, they would be less likely to benefit, for example, from virtual video visits, and also, to the point here, less likely to potentially connect with those whom they loved who weren't living in their community because of that isolation. So I think there are folks who are specifically being left behind. You highlighted this over and over again in your presentation, Ashwin, that people who have less resources are in a much more vulnerable situation. And I think part of our opportunity is to say, how can we do some level setting? What does that look like? How do we as communities really make sure that nobody is left behind?
And building on that, thank you also back to the principle of meeting people where they are and trying to understand their lived experience, trying to understand a little bit more about choices that people are making in the pandemic around social interactions as they balance the need for health and safety in a physical sense with health and safety in an emotional and psychological sense from connection. And so choices that might seem riskier than we might perceive on the outside might be a strategy to address the risk of the sequela of loneliness and isolation.
What a great point. You know, the other thing that I was reflecting on is there was this report that came out from the AARP that basically showed that loneliness and social isolation is now being experienced in a widespread way across all age groups. And in some respects, among younger and older groups, and offers this tremendous opportunity for intergenerational connection. And seeing the greater sort of efforts in that area has been, I would say, another sort of bright spot in the pandemic with just all kinds of creative ways that people from different generational walks of life are seeking out each other to learn from each other and to feel a sense of connection in new and different ways.
Thank you. I think sadly we're like running out of time, I think, and I will be getting ready here to turn it back over to Rebecca and Peggy. But I think as a summary from what I've heard, we have a lot of work to do. Yet we have learned so much, really from the research and really from our own lived experiences and from those around us. I think this is an opportunity for us, Karen, as you said, to really think about the lived experience. And all of this is about risk mitigation. I think your point about how do we balance, that physical health and safety versus our emotional health and safety. And I think we went to one extreme during the pandemic, and I think it's forced us to realize, hey, what is the middle ground, and how do I capture both, or how do I balance both of those risks and those opportunities for me to connect with others? On a personal note, some of you know that I had the fortune during the pandemic to have my mom come live with me for several months. I think had we not been in a pandemic, that wouldn't have been an opportunity. And, that was a great way for us to connect, and something that I will cherish. So I am so grateful to all of you for being my friends and colleagues and mentors and partners in this path. And I will turn it over to Rebecca and Peggy now. Thank you so much.
Wow. Okay. Let me echo those thanks and embrace the challenge. I've taken so many pages of notes here, and I have just a few minutes to sort of provide some commentary. First thing I wanted to say is that so much of this work is taking place within the context and construct of the growing age-friendly health systems movement. And if you're familiar with that, you know that the sort of core principle has to do with the 5 M's, one of which is what matters. And to the extent that that becomes sort of a foundational way that clinicians think about offering optimal care to older adults, I think embracing that question, that the importance of that patient-centered construct is really going to be helpful, because of course when you ask older adults, especially those near the end of life, what matters, often what they will describe is relationships and human connection. And so the way to proceed flows from that. Secondly, I wanted to amplify the call that was sort of threaded throughout this discussion for the importance of acknowledging that these issues arise differently for different subpopulations, and to say that we need to continue to elevate and fund cross-cultural adaptations. I know there's a great one that's happened for the UCLA loneliness scale, and there's been some good research looking at the effectiveness of that. We need to do that sort of across the board. And as we are generating interventions and responses, we need to, continue to recognize that one size does not fit all, and include representatives of those subpopulations with us, alongside us, as we design those interventions. And then finally, just to state the blindingly obvious, if we want any of this good work to get to scale, we're going to need attention on the policy and regulatory and payment arena to really make that happen. You may be aware that the Senate Finance Committee is now looking at an omnibus bill addressing the unmet needs, the mental health needs of the populations as part of the response to COVID. And I think within, because of the way the funding flows to CMMI and some of the other bodies, this is a real, fantastic opportunity for all of us to advocate for some of the policy and regulatory changes that could make that happen. And some of that has to do with recognizing and testing different kinds of billing codes. And then other, very pragmatic things like making long-term care licensure contingent on the widespread availability of internet connections, so that older people living in those congregate facilities can, participate in telehealth and communicate with their loved ones even when they're not able to come into the facility. So this is really great work, and there's a lot more to be done. And I'll stop there and pass the baton to you, Peggy. Take it away.
Thank you so much. And thank you to our moderator and fantastic panel. I also took a number of notes and just found myself nodding my head and agreeing with much of what you said. It's very clear to me that quality of life for people with serious illness is about whole person health. And that, for me, that really is acknowledging that our health is impacted by the physical conditions, our behavioral health, and also the social determinants that influence our health, such as food and housing and transportation. Our health and spirituality, actually, and connection. Our health is interconnected, and our health care should be that way too. So I loved your discussion about the need to focus on the needs of the person and the resources available to a person, thinking about we are not all the same, and we need to have really, truly person-focused care. I really enjoyed the conversation about, when you are treating someone with heart failure, you can't just treat that medical condition, but you need to open up the discussions to address behavioral health issues and social determinants of health. I appreciated the comments that we need to support clinicians who may be uncomfortable asking questions about meaning and purpose or loneliness and social isolation. And I especially like that as we think about quality measures in this domain, we need to think in terms of patient experience and patient reported outcomes in terms of how sensitive the clinician was in the conversation. And I think, clearly this is not a check the box exercise, but an opportunity to listen and build rapport. And I think the panel made the really great point that sometimes screening for loneliness in and of itself becomes part of the intervention. The pandemic has impacted all of us, but we have not all experienced the pandemic in the same way. I do appreciate the comment that the pandemic, a silver lining may be that the pandemic has normalized conversations about loneliness and isolation. And, we need to keep open that opportunity for the integration of social and medical goals, and simply acknowledging that people do want to be heard and do want to be asked. So I think in closing, I appreciate so much this conversation and the leadership shown by our panelists. I think it's up to all of us to continue the dialogue and continue to invest in a future and a healthcare system where all people have equal access to what they need to achieve integrated health, where we create a system where no one falls through the cracks or is left behind. I know that's a tall order, but clearly we see that this is a need and it's possible. On behalf of everyone and the team at the National Academies, I would like to thank all of our participants today for taking the time out of your extremely busy schedules to share your research and your experiences and your expertise with us. As noted at the outset of the webinar, this webinar has been recorded and will be archived along with the recordings of the previous 2 webinars at the website listed on the slide. We encourage you to share this link with your colleagues and your networks. And for more information about the work of the Roundtable on Quality Care for People with Serious Illness and the Forum on Aging, Disability, and Independence, please view the websites, which include previous information about previous webinars related to the COVID-19 pandemic. Again, we want to thank you very much for your time today. Thank you to our fantastic panelists and our moderators. And thank you to all of you for joining us for this very important conversation. Take care.